Thank you, Libby. It's a pleasure to be here. And just to be official about it, I am a member of APA's Division 27, which I- my background is in psychology. I started in physiological psych and got my master's in that, and then switched to community psych. And it really was about a desire to kind of get in the boat and go downstream, meaning there were so many services that were available for people not yet in recovery or in early recovery, that after 27 years in the carceral system in Georgia, particularly with the State Board of Pardons and Paroles, I wanted to kind of see what was available for people who were 5, 10, 15, 20 years into what they would refer to as progressive wellness or recovery. And so that's what led me to start the CARES Academy, which is the CPSAD credential or the training that leads to that, and then the Forensic Peer Mentor training. So this is a session where I hope we'll be able to talk about the Partners for Change outcome management system. And I'm not here to sell anything. Everything I'm going to talk about is available free of cost. Now, there are paid versions that you can get, but I just want to make sure you understand that I'm not here selling something. I am a certified trainer with better outcomes now. But again, you can get all the tools that I'm talking about without paying a penny. Just have to go on some websites. So I want to go through what are the top 7 reasons for using PCoMS, as we commonly refer to it. Want you to be able to assist with doing valid and reliable peer self-assessments, and quantifiable peer-based service outcomes based on 3 key performance indicators. And it's about how we as peer recovery support service providers intentionally get better over time. And it's not just sitting in rooms getting trained that I'm talking about here, but it's how do I actually have interactions that have value and meaning to the people who I am serving, in addition to myself. And it's kind of that intentional peer support notion of this being a mutually beneficial and mutually challenging relationship that is at the heart of effective peer recovery support services. So it's about me being able to direct my own professional development, so to speak, as opposed to having somebody else tell me, well, this is what you need to do. And you go get these continuing education hours and you check the box and everything's good. I want to feel like 5 years from now, I'm better at doing this than I was 5 years ago. And that's up to me. It's interesting to me how will tell peers, yeah, you need a recovery plan, but we don't do it for ourselves. And so that's part of what this is about. And then lastly, be able to participate in appreciative performance support that enhances the service providers both currently experienced and your cumulative career growth. So it's about how do you come out of individual interactions or group interactions and have that sense of that was okay. Here's some things I can do better next time. But then also, do I see myself getting better at this over time? And fundamentally, to me, that's what I prefer to call performance support, to make the real clear distinction between that and what would, in put on my other hat, would be called clinical supervision. Those two things are not the same, or at least I hope they're not for you. So I want to invite you to participate in some polls just to find out who's here. So if you would open up a web browser and type in responseware.com, and you should see something similar to what's here on the left in terms of this picture, where you get a box that says, hello, guest. And then if you would just type in PCoMS in that box.
So if I can just add, in order to do this, you might need to make your Zoom screen smaller so that you can see a browser on your screen. I know not everyone is familiar with being in a Zoom and seeing a browser at the same time, but you can share your screen so that with part of your screen you're seeing this Zoom presentation. In the other part of your screen, you're seeing your browser, and you can go to the website that George is talking about.
Nice. So when you get there and you've logged in, how about shouting out Shazam?
Shazam.
Good. At least to know it works for one person. Uh,
I put that in the chat.
anybody else?
Shazam.
There you go. Thanks, Phoebe. Okay. Well, so first poll question. Who are you? Are you an academic or a teacher? Are you a licensed medical profession, meaning a doctor or a nurse? Are you a licensed behavioral health professional? Or maybe you're a certified or licensed addiction professional. Maybe you're a certified peer specialist or a CPS supervisor. Or maybe you self identify as a person in recovery or an ally of a person in recovery, or you just discovered that, gee, I'm in the wrong room. Looks like we've got 3 responses so far.
I know
George, this is Kim. I'm not at the survey site. It's not able to do that at the moment.
Okay. Well, I appreciate you letting me know.
Yeah.
Can you type the word what we supposed to put in into the session? So
when you see this poll, you should see letters at the bottom like a keyboard, and you're going to click them.
Did you see it? Okay. Well, not a big deal if you weren't able to complete it. Looks like half the folks are CPSs. We got several supervisors, several folks who identify as a person in recovery, and then several more who are allies. And I think that's relevant because it's how each of these types of individuals can bring value to the services that are offered by certified peer specialists. So, second poll, on a 100-point scale, with 100 being I can teach others how to use Partners for Change outcome management system, and 0 equals I've never used PCoMS, how would you describe your current competence using the PCoMS scales? And you can see it goes from newbie, you can't even spell PCoMS, you have no experience with the tools, all the way to 90 to 100, you're expert and you're a certified PCoMS user or trainer. And there's all those degrees in between. Okay, Jessica, you're an A. Good to know.
I'm an A.
Yeo, is it Yeo? Y-E-O? Yow?
like, yo, like what's up? Yo, yo, yo.
Yo, nice. Thank you very much.
What are you living?
Our survey says, yeah, hardly anybody has ever used or heard of PCoMS, which is fine. So, next poll question. How many decades of research show that those whose ratings of the quality of the Helping Alliance is the most valid and reliable indicator of outcome? Would that be the client, peer, or residence rating of the outcome, or excuse me, of the quality of the helping alliance? Would that be the service provider's rating of the quality of the helping alliance? Or maybe you think it's the service provider's supervisor's rating of the quality of the helping alliance. Or maybe you think, yeah, the truth is nobody really knows. Jessica's a solid A. Such a catchy tune. Our survey says, okay. Well, in fact, the research is pretty darn clear, and it has been for about the last 75 years. So this is a picture of Dr. Barry Duncan. He is one of the founders of the Partners for Change outcome management system. And there's a couple of references here on the screen for those who are therapists or who want to become therapists. Highly recommend his On Becoming a Better Therapist book. For peer services, there is on the right, What's Right with You? Debunking Dysfunction and Changing Your Life. That's also by Dr. Duncan. And in fact, this is a text that we require here in Georgia as pre-reading for the CARES Academy. And it's just it's a way of helping people start to make that mind shift away from, or I shouldn't say away from, but that allows people to move beyond thinking what I've got to do here is the medical model. And so at one point, PCoMS was in SAMHSA's National Registry of Evidence-Based Programs and Practices. Of course, they did away with that, I don't know, 8-10 years ago. But I do want to mention one more resource, and you can get this from the Better Outcomes Now website. It's a manual that will basically tell you everything you need to know about how to implement PCoMS. So why do PCoMS? Just relatively quickly, I want to run through 7 rationales. The first one is it solves the bad and the ugly problem. So the bad and the ugly are the folks who come into behavioral health or other services and who don't respond or who even get worse. And it's a way of identifying who those people are so that we can begin to have some conversation around what do we need to do differently. We being me, the service provider, and you, the service recipient. So as of this point, there have been 10 randomized clinical trials, a large cohort study, and 3 benchmarking investigations that unequivocally show that PCoMS improves outcomes and increases efficiencies. It's been implemented in Canada and Saskatchewan, Norway, as well as China, and in many, I should say, several U.S. state departments of behavioral health. So it's got applicability for the traditional sort of community mental health center, as well as larger organizations that provide behavioral health services. It is also atheoretical, meaning you don't have to change a thing that you do. It's not about you suddenly having to switch from doing what you're doing now to doing this other thing. What it does require is for you to take about 5 minutes at the beginning and 5 minutes at the end of interactions to simply administer some tools and get feedback from the service recipient. And it's applicable to people in all diagnostic categories. And then fourthly, it enhances the research-based factors related to successful outcomes. And I want to dig into this a little bit deeper because you can pick out what's your favorite here. And what do you think is the most impactful based upon research of all these different approaches that are predominant now in the behavioral health field? And if you don't see what you really like on there, well, chances are it's kind of like, do you prefer Coke or Pepsi? Well, I'm in Atlanta, so obviously the answer to that is Coke is better. Although I would probably be thrown out because I like Diet Pepsi best of all. But the fact of the matter is, this is a debate that is still raging. All of these are called evidence-based practices.
Mhm.
But the fact of the matter is, what's most relevant isn't the therapeutic approach or the model or the technique that's being used. So, of all the factors that affect outcome, treatment model is the most potent. Would you say that's true or false? If you want to put it in chat instead of doing the opening up your web browser again, you can do that.
I think it's time we stop. Children, watch that sound. Everybody look what's going down.
Yeah, I'm an old hippie. Okay, so yeah, actually, Jessica, that's exactly right. And most people got it right. I mean, I think the fact is the answer to this question is false. Even though what we're told is you got to go to training and learn how to do evidence-based practices. Well, that's not irrelevant, but it's not the most potent factor.
Mm.
So this is, again, it's been 50, 75 years worth of research that's shown this. And this is some work by Bruce Wampold, who, if you're familiar at all with therapeutic processes, he's one of the gurus, if you will, of therapeutic research. And what his research shows is that the alliance, the quality of that helping relationship is what is most impactful, even more so than allegiance or technique. And then you can really dig into this and identify that there's over 1,000 published studies that show it's this combination of factors that have the biggest impact on outcomes. And it begins with the CPR, the client, peer, or resident's theory of change or mind, what they think about how to change and what to change and what resources to utilize. And then agreement on goals and meaning and purpose. And then also acknowledging the relevance of that service recipient's ways of going about making changes. And then down there at the bottom, at the absolute foundation of this whole approach, is the client, peer, or resident's view of the quality of the therapeutic relationship or the helping alliance, as the case would be in peer services. So, at the risk of putting everybody completely asleep because of all the data, one more slide that just simply shows what the client walks in the door with, or in this case, the peer, has much more impact on outcome than anything the service provider does themselves. And it's about our ability to tap into that is so vital. So the relationship is the thing that we have the most control over, that has the most impact on outcomes. And you don't often hear clinicians talk about this, but the fact of the matter is it is where we can have the most influence, and learning how to do that is a big part of what makes peer services as well as clinical services, but obviously here we're talking about peer services, have more impact. So you may recognize that guy on the right, or not. That's actually Carl Rogers. who published a paper that changed psychology radically way back in 1957, titled The Necessary and Sufficient Conditions of Therapeutic Personality Change. And just so you don't think I'm basing this on something that was done in 57, Michael Lambert, again, one of the research gurus in terms of therapeutic outcomes, did a meta-analysis and discovered that empathy, positive regard, and genuineness each is more powerful than any technique that you can ever wield. So I don't know where you come from, but from where I come from, 31, 27, and 24 are bigger numbers than 20. And that's really all you need to take away from this slide. It's not that those techniques are not relevant, they are, but how you connect with the other person and your ability to have empathy and to show positive regard and to be genuine in the relationship or in the interaction is the most impactful thing that you can do. So the other rationales real quickly, PCoMS incorporates the known predictors of success, and that is early change and the quality of the alliance. And the research has been pretty clear on this. If people don't change within 3 or 4 interactions, there's a very high likelihood that they're not going to. And so how do we monitor that? How do we tap into that is a key question. But we know that PCoMS privileges the service recipient's voice in all facets of service delivery. It's client-driven, it's recovery-oriented, and it's individually tailored so that it promotes social justice. And I'm not going to show this video, but that's a video where Dr. Duncan actually talks about the social justice impact that PCoMS has. And then the last thing is there's a significant return on investment. And multiple studies have shown that PCoMS reduces the length of stay by 40 to 50%, and it impacts cancellation and no-show rates by 40 and 25%, respectively. Now, you might say, well, why do we want to reduce lengths of stay? Well, part of the challenge is, I don't know, it's about being able to provide services that the service recipient finds relevant. And so that they are the ones that set how long they stay engaged in services, not the clinician or not the program, in order for you to be judged as having met some standard that says you're okay now. It's more about hearing what the peer thinks in terms of their progress. And for me, as a peer recovery support service provider, I kind of think of this as my job is to work myself out of a job. I want my peers to connect to a network of recovery resources in their community so that they don't have to rely on me. And it's that shift in attitude that I think is one of the things that demarcates clinical services from peer services. And it's about us being able to show that what we're doing is having the intended effect from the perspective of the service recipient. So these are the tools. Anything stand out about those two forms? Is there anything that's weird or it's missing?
Let's see.
Anybody?
I don't see medication on there.
No, you don't see medication. And you don't see any numbers. So the outcome rating scale basically is about you thinking back over the last week, how has your life gone? And to put a mark on each one of those 4 subscales, indicating on the first one, how's your personal well-being been? From marks to the far left, can't get any worse. My life is absolutely awful, to marks on the far right. My personal well-being is perfect and can't get any better. Marks right in the middle. I'm doing okay. And then secondly, how has your close relationships, what most people would call their family, how have those relationships gone in the last week? Again, can't get any worse, can't get any better. Okay, right in the middle. And then thirdly, how are you doing socially? Most of us have jobs or we go to school, and we hang out with friends, and it's that connection piece again. I always like to throw in here as well. So, how much fun have you had in the last week? And I'm kind of big on the fact that if I ain't having fun, I ain't in recovery. There's something really wrong. And then overall, just generally, what is your sense of well-being? And again, you put marks on those 4 lines, and it's about then pulling out a ruler, a 10 centimeter ruler, and marking the number that's associated with where those marks on the line. And then having a conversation about, so what stands out to you about this? And using this as a way of tracking the peers' sense of how their life is going from interaction to interaction, from week to week. And doing it in such a way that it empowers their view. Now, I'll tell you, I started doing this back when I worked for the Georgia Parole Board, and it was not uncommon to have people who would come to the parole office the day after they got out of prison, and they would fill out this form, and guess what they wind up being? They would show up as a 38, 39, or a 40. And I'd be like, well, tell me how your life is so great and you don't have a job. You don't even have a way to get around. And those clothes that you have on your back don't even belong to you. And so it sometimes takes a little work to get people out of the frame of reference of what I'm doing here is I'm rating how well I like the hamburger at McWaffle Hut, because that's the way a lot of people see these sorts of scales. No, this is about you being able to reflect on your past week's experience and register how you are experiencing life over the last week, not just right now. And some people, it takes more time than others to kind of get out of that. I'm a consumer and I'm doing a consumer evaluation here. And so that's the outcome rating scale. On the right is the session rating scale. And I will point out, if you look at the third subscale, it's got the T word in it, therapist. And so I want to suggest that much more relevant is the relationship rating scale, which is the one that is useful for peer service providers. Libby, you had your hand up. Did you have a question or a comment?
Well, I guess my question is, if you ask a person, how are you doing?
Mm-hmm.
Are they more likely to be negative about like their just in the moment situation than if they think back over the previous week? Like, does changing the time frame of it tend to shift the what the person says?
Absolutely. And so it really is about being explicit that you're thinking about the last week, not just how you're feeling right now.
Do people have a more positive view of the past than they do of the present?
No. And I think part of what you're getting at is the fact that there is a social expectation, particularly in behavioral health programs, that somehow I'm not as bad off as I used to be. And to present myself with that sort of glowing expectation, it can get in the way of really being able to help people focus on what are the challenges that they experience. And so if I get somebody who is rating themselves as a 38, 39, or 40 over and over and over, what I often will do is say, well, so why are you here? And the answer to that more often than not is, well, my probation officer, my parole officer, or my spouse, or my boss, or whatever thinks I need to be here. And I may ask the individual, thinking back over your last week, how do you think your wife or your spouse or your boss would rate you? And then compare those two to get a different perspective. And that begins to kind of undo some of that expectation that I should be better now. And I'm trying to convince you that I don't really need services. I'm good just the way I am. Does that kind of get at it? Good. So these are simply the two scales that are included in the Partners for Change outcome management system. And again, the ORS is administered at the very beginning of interactions, and then the relationship rating scale is administered towards the end of interactions. And it's the same sort of, on the left-hand side, you didn't feel understood, respected, or validated. On the right-hand side, I did feel understood, respected, and evaluated. Or we worked on and talked about what I wanted to work on and talked about. And I felt supported and encouraged in my change effort. The role here is a good fit for me. And then overall, the relationship is right for my change efforts or not. And so it opens up this conversation about what can we do different next time to make this better. And that's the fundamental question that gets us to where we really need to go in terms of the services that are being provided. So the real trick here is that these have been shown to be valid, they are reliable, and service providers recognize that they are feasible. In other words, you're not having to administer a 35 item questionnaire that takes 30 or 40 minutes to just have the person fill out. I mean, again, 5 minutes is about what it takes to do either the ORS or the relationship rating scale. And you don't have to change anything you do between the beginning and the end of your interactions. So, what are the 4 research-based factors that are responsible for change across disciplines and across models? Well, empathy, genuineness, positive regard, and feedback. And that feedback from the service recipient is what is missing in most cases, in most clinical conditions. So, let me ask a little more pointed question. And that is, what percentage of your clients, peers, or residents do not improve or deteriorate? Would you say, I don't know, would it be 25, 35, 45, 55, 65%, or now you definitely know you're in the wrong room?
When anybody tells you words and ideas can change the world,
Our survey will say, yeah. And frankly, that's the answer that is most difficult to swallow. It's about recognizing that I almost don't pay attention to that, or as more commonly, if there are people who aren't making adequate progress, that's because of something inside of them. You know, they've got an ick or an ism, and that fundamentally that's what's causing this. It's not me. I mean, I'm here and I'm doing this wonderful work as a forensic peer mentor who's got all this lived experience. And if you've been to jail and I've been to jail, I ought to be able to tell you what my experience is, and you come away with a whole lot of hope. Well, that's not how it works. It's more about, can we do something to actually monitor whether or not peers are making progress from their perspective, from their point of view. So this is Michael Lambert. Again, he's one of the gurus, if you will, of therapeutic research. And I want to show you a relatively quick video and ask you to specifically look for in this video what his research shows in terms of what's the percentage of clients who don't change, who deteriorate, who improve, and who achieve recovery. And then also note in the first slide, what does he suggest be done about treatment failures?
The question really becomes, can we see as people go through treatment that they're getting better or they're getting worse? And can we predict their final end of therapy functioning? And then can we alert clinicians to this?
And therapists, of course, are notoriously bad at doing this. We think that we can, given enough time and investment, we can change anybody. That seems to be the attitude. Therapists, I guess, have been measured consistently to not be very good at predicting treatment failure.
Yeah, exactly right. First of all, there's a problem that about 8% of adults actually deteriorate, and about 40% don't change one way or the other.
In psychotherapy, yeah.
Yeah, in psychotherapy. Then the second part of the problem is that clinicians are very optimistic about how their patients turn out and how they're doing in the course of therapy. We actually did a study on whether therapists could predict treatment failure. And the clinicians out there, although they're confident they can do this, so are our clinicians.
So did you notice that between 40 and 61% don't change? And then another 3 to 14% actually get worse. So we're talking almost 75% of folks who show up for behavioral health services, they don't make progress, and in some cases actually get worse. So it's not uncommon to have a 20 to 30% success rate or improvement rate. And then fundamentally about 20% will actually achieve what would in the research literature be considered recovery. Those are startling statistics to me. And I don't know what sort of programs you're familiar with, but the majority of the programs that I've worked with will say things like, oh, we have a 75% or an 80% success rate. Well, that's not what the literature says is most common. And for a lot of programs, if you're cherry picking who you will allow to complete your program, then you might wind up with that high of a success rate. But for most programs, if you count everybody who walks through the front door for the first time, your success rates are going to be significantly lower. So what do you do about treatment failures? Yeah, so is it self-defined improvement or deterioration? Good question. And how do we go about identifying that is a key part of what I think PCoMS can help with. Was there something else you wanted to say about that, Libby?
Well, I just think that people have very many different meanings that they give to these words. Like even the word recovery is defined in so many different ways.
Yeah.
Like in the 12-step world, it would probably be, did the person achieve sobriety or abstinence? But many people see it as a much bigger category. So
absolutely.
And then you also have a problem of how do you define abstinence?
Yeah.
So it is, but I think asking people, do you think you're doing better, might be a valuable question.
Mm-hmm. And I'll show you a progression of questions that I think will get at what you're talking about. But John Kelly and some of his research at Harvard has clearly shown that there are far more people who have resolved alcohol and other drug problems, but who do not refer to themselves as being in recovery than who do. And part
Right.
of that's because of the stigma.
Mhm, mhm.
So, yeah, that's a great point. So, what do we do about failures? Well, Michael Lambert suggests we set up progress alarms. We look for support tools, and we are intentional about soliciting feedback from the service providers. And frankly, that's exactly what Better Outcomes Now and PCoMS allows people to do. I think in the interest of time, I'm going to skip this, but there are Better Outcomes Now is the computerized version of PCOM. So you can go to Better Outcomes Now and download the ORS and the RRS, and I'll show you how to do that in a minute. But with Better Outcomes Now, you actually get immediate response that's grafting out the history of that individual and their scores on the ORS and the session rating scale. But again, I think I'll skip over that video. So here's what one of the factors, or here's one of the sets of skills that are included in the CARES Academy, as well as the Forensic Peer Mentor training that I facilitate. And that is an individual recovery check-in. And I want you to notice number 1, about midway down the page. And the question that it begins with, in contrast to the medical model that says what's wrong with you and what do I diagnose you with in order to be able to figure out what's the best approach to use, the peer support model begins with asking the question, what's right with you? And so it immediately gets into and it opens the door to have conversations with people around what they're finding is positive in their life and what are their values and what are the things that they're seeing that's beginning to have a positive impact. Yes, indeed, what they are grateful for. And so I can't tell you how many times I've asked that question and people have kind of looked at me like, are you kidding? I don't know what to say. But as they get used to the interactive style, it's really interesting. And particularly if you do groups, I'm going to show you an outline of that in just a second. You don't want to be late for group because people like talking about this stuff as opposed to what's wrong with them. And if you're late for group, they're going to start without you. So there's another form that's available on my website that allows you to document as you're having the conversation. It goes along with the other form, but you see, you start with what's right with you, then you complete the outcome rating scale. And then number 3 is, what in the last week has been your experience of the core challenges? It doesn't say core on here, but by core, I mean craving or recurring experiences. Most people come in looking for some relief, or they recognize that there are things that are happening in their life that they almost don't have control over, but they keep happening over and over and over. If I'm depressed, I can't get out of bed. If I'm schizophrenic, I hear voices. If I have an alcohol and drug problem, I have this urge to drink or to use drugs. And it's much more appropriate to ask, how is that craving or how is that recurring experience been for you in the last week? On a scale from 0, hadn't even thought about it, to 10, I experienced it and I used, or I had a recurrence of symptoms, than it is to say, did you drink last week? So it invites the person to do their own self-assessment and then to use their own theory of mind or theory of change in order to frame and characterize whether or not they are experiencing progress or whether they're kind of moving in the opposite direction. So this is a handout that I like to use in what I call recovery, action, and progress, or RAP groups. And again, you can see that it really does begin by the same process of, as the facilitator, I'm going to go through and talk about, well, here's our safety and respect guidelines. And that number A4 question is the most important one. What other guidelines will help make this a more safe and respectful place to maximize your engagement today? And add those to the cultural guidelines. But then, as the facilitator, I'm going to do a check-in with one of the participants in the group. And the question I'm going to start with is, what's right with you? And then immediately go into talking about your ORS score. And again, your core level. And then ask about how safe or sober is the place where you're staying tonight. And then would you like more time to discuss a topic after everybody is checked in? And what do you think I should do if I say how safe and sober is where you're staying tonight and somebody says it's a 0? How should I respond to that? Anybody?
Maybe,
Go ahead, John.
you could say, well, what could you do to change that?
Perfect. Nice. And so, and the difference is, and I can't tell you how many times I've done this training, and I'll ask peer service providers and clinicians, and their first response is, well, I'll pull out my list of resources and I'll tell them this is where they can go stay tonight. And I have to push back and say, but you don't even know what the person considers to be a safe or a sober place yet. And it's about acknowledging the relevance of the resources the person walked in the door with, privileging that over anything that you might pull out of a drawer or any list that you might have of resources that you think are relevant to solve the problem. And I think that kind of fundamentally illustrates the difference between an informed peer approach versus a clinical approach. And so once I've gone through this with the individual, guess what? I'm done as the facilitator. It's up to that person to then do a check-in with someone else in the group. And it's about modeling what I call the pink Orsi. You see that pink rocking horse down there on the handout? Well, that pink Orsi stands for practice intentionally not knowing, which is fundamentally intentional peer support. But by using a set of relationship enhancement skills that begin with open-ended questions, affirmations, reflections, summaries, and last on purpose is information giving. And so it's about how we're able to integrate those skills and model those skills and teach other people how to do it. And I will always say, if you've got people in your life that you don't want to improve your relationship with, don't use the pink Orsies. If you do, it's going to improve the quality of your relationship. If you do it consistently and learn how to do it with people that are in your network, that's what we're trying to get at. And I would say that's kind of the generic goal of peer recovery support services. Are you referring to what are you referring to there, Libby? Is it
how safe and sober is where you're staying tonight? You could say, well, have you ever been in that place before, and how did you handle it last time?
Exactly. And what worked, and is there something I can do to assist you with getting back there? Mm-hmm. I'll tell you, this is not a good story, or am I proud of it? But I actually had this happen to me in a clinical group. And I told the woman, well, here's where you need to go. And she looked me dead in the eye and she said, over my dead body. The last time I went to that place, the owner raped me. And I was like, oh my gosh. So it took me back, and obviously I jumped the gun and made a suggestion without spending time figuring out what that other person's frame of reference was and what resources they would find useful. And ever since then, it's been a whole different ball game for me.
What are the beat?
So, how much time have I got left? 15 minutes.
I have a question.
Okay, good.
It refers to your previous slide.
Oh, okay.
When I've talked about motivational interviewing with people and this notion of using ORs
Yes.
rather than providing a solution,
Mm-hmm.
it often brings up for people a sense of, it's very uncomfortable because people feel like, well, am I behaving in an ethical way? If someone says I'm hungry and I'm aware of a food bank, don't I have an ethical responsibility to share that resource with them, knowing that it could address like a life situation? Like, people feel like if I have access to resources, I have a responsibility to share them, and I have like being silent on that is in a way being complicit with someone's suffering. So I think this is kind of a moral dilemma that we sometimes face as we want to support people and want to stay out of being the one that provides everything for them and affirm their strengths and their ability, and also feel responsible, like, well, shouldn't I make that information available to them because that could really help them? I don't know. I just find that people, especially people who've been in that situation where they feel that services and information were withheld from them, they don't want to be in a position where they're perhaps replicating a trauma that was done to them. So it's complicated.
Sure. And it's really not about withholding resources, but as a peer recovery support service provider, I'm not a case manager.
Right, exactly.
And at the same time, I want to be I want to be able to go home, put my head on my pillow, close my eyes, and go to sleep at night.
Yeah.
As opposed to worrying about, should I have done something more for this individual today?
Yeah.
And there's not an easy answer to this. Mm-hmm. And it's about helping us become more attuned to what's going on inside of us. And it's related to the idea that peer support, you hear a lot of people talk about it's sharing my lived experience with others. Mm-hmm. And I don't disagree with that, but I think there's an element that happens before you share that lived experience that specifically focuses on being in tune with how your lived experience is showing up in the here and now. Mm-hmm. So if I'm feeling bad, or if I feel afraid, or if I'm ashamed, or whatever the emotion is, can I recognize that within the context of this interaction and still push through that enough to be open to hearing and understanding and being empathetic with that other person's frame of reference or point of view first? Mm-hmm. And that's probably, I think, the hardest part of being an effective peer service provider, because the tendency is I want to fix this so that I'll be okay.
Yeah. I agree. I mean, it's built into the peer role because we tend to empathize a lot because we have so much in common sometimes with the people that we serve, and it's really hard to not get enmeshed, as they say in the clinical world, to be able to see where I stop and the other person starts, and it's their situation, not mine. But we tend to want this job because we care and we want to alleviate other suffering. That's why we come to it. We don't just
Absolutely.
leave that at the door when we walk in to our place of work. I mean, I'll give you an example, George, of how this hit home for me, which is was working at our drop-in center, and it was late because we close at 9:30 at that location. And there was a young woman there in her early 20s, and she was high as a kite. And we all were leaving and walking out the door. She was so high, she had trouble walking. And I just wanted to wrap my wings around her and fly her off to some kind of safe cloudland, like
Sure.
I was just horrified that she was going to go out on the streets incapacitated
Yeah.
and not in her right mind. And all I've got is open-ended questions. You know what I mean? It just, in that moment, it didn't feel like I had enough at all
Just
to
wasn't
address
adequate.
this. Yeah. So I just think that, that feeling that kind of pain for others and seeing the danger that sometimes people put themselves in, it is very hard. I mean, I have found it to be hard, and I think it is perhaps
Sure.
for others too.
Well, and I won't ask you what you did to address that, but that to me is really where performance support, that's the essential role of peer performance support. As a supervisor, do I have an environment that is safe enough for people to come in and share that kind of experience without me having to say, oh, as the wise supervisor, here's what you should have done.
Uh-huh.
But just to kind of sit in the suck and acknowledge that this is hard work.
Yeah.
Yes, ma'am.
Me?
Yes, ma'am.
So I was just kind of feeling when I was listening to what you guys are talking about, and one of the things that I felt as a peer support specialist, and before a person that saying themselves is a peer support specialist, and from the part that you have your recovery to you become, good enough, better enough, now you can help other people. In between those, I think a lot of people, and then I felt really, really, I talked to Libby about that. I felt very skeptical or feel danger to a lot of people feel like, oh, I'm sober now, or oh, I'm no longer feeling sad and I can go save other people now. And I think it's such a big gap in between that is
No
missing
question.
before they jump to like, I can be a peer support specialist now. But that whole chunk of like, wait a minute, I felt what is missing is that whole point is you need to go back when not just like I exploded when I have my breakdown, I go through a period of time recovery from that. But wait a minute, now you put it together in one piece. But wait a minute, what happened in your life that caused you to get exploded? What have happened in your life that you're so unmanageable that you get yourself to the point that you get exploded? and
Sure.
and I think that is the part that people did not do that homework, is to go
Yes.
back in time and check and find out what are the fear of yourself, what are the things that you cannot honest to yourself, what are the part you cannot feel your feeling, and everything, and go back and find that roadmap and trace yourself and know that, holy cow, this is what happened to me, and understand inside out who are you, why you are that way, and how do you actually overcome that? Have you overcome that? Do you know what's going on with you before you go save other people? Do you know what is your fear? And what is the fear that you're still fearing that you're escaping? Like, it's not that you go find out and you need to have all the answer, but at least know where is your soft spot. At least know where is your landmine that you're still working on yourself. And I think that part I can understand that you're a peer support specialist, but people did not even do that part and jump and saying that I could be a peer support specialist. That part is scaring me.
And I so appreciate that because I mean, we caught a lot of grief because one of the requirements to become a CARES is that you have to have at least 2 years of sustained recovery, and ideally abstinence-based recovery. And part of the reason for that is exactly the kind of work that you're talking about that people often will skip over. We've got folks here in the state who want to start a forensic peer mentor training for prisoners, for people who are still in prison. I couldn't be more adamantly against that than anything else that I've tried to do in my professional life, because until you've had that reentry experience and have been successful at it, how in the world are you going to work with somebody? And it gets to exactly what you're talking about. You got to do your own work first. And it's that vulnerability and having that sense of psychological safety. And I'm not saying don't help people, but don't make your health and well-being contingent upon the people you provide services to just suddenly having no more problems in their lives, because that's not going to happen in most cases.
No.
Jason?
Yeah, thank you. I just wanted to share a little bit about our experience in well, I think one of the things that I'm hearing on feedback and in this forum is that so much of supporting people's availability for their own self-evaluation comes in the relationship element of the peer support. I think that really stands out. We, in 2013, I think it was, we developed a program. We developed two programs. One was a peer respite that is still up and running and works. And the other was something we called rapid recovery, where what our goal was to have, you know, an alternative to the kind of clinically based intake stuff that the Department of Mental Health was asking us to do, that simultaneously helped people understand the issues that they wanted to deal with, and then be able to one, document that, and two, find the resources. So it was essentially the list of, you know, are you an addict kind of questions from all the different self-help support groups with all the different life issues. So sex issues, money issues, mental health, all of that. And we tried to do a survey that was succinct, that wasn't too much. Yeah. But what we found was that often it was really painful for people to go through, in terms of the story about what had happened to them, things that they needed to deal with, things they wanted better. And as an entry mechanism into peer services, it in a sense, I think, was off-putting for some people, because it was so heavy. And we learned that, you know, for people that are maybe like in recovery or have defined what their recovery looks like, it's a potential tool. Or once a relationship with peer support is established, it's a potential tool. As a peer support specialist kind of can use disclosing and talk about that process themselves. I just wanted to share it because I thought it was really interesting. I like learning from our failures.
Yeah.
And there are plenty.
And it really is, I hate to use the T word because it's so overused, but it's almost like you're traumatizing the person by having them go through this laundry list and to say which one applies to me and which one doesn't.
Right.
Well,
we had people say that. We had people say, I feel like a failure. Yeah.
Yeah. Well, and that's why starting with what's right with you makes a lot of difference.
What are the be?
Well, so do I have like
You have a
12
little more
minutes?
time. Yeah, go ahead. Go
Okay,
ahead, George.
good. So now I do want to get specifically into how do we do performance support, and in particular using an appreciative PCoMS approach. And by appreciative, I'm really referring to appreciative inquiry. And it's about promoting currently experienced and cumulative career growth. So we'll just skip this one. But the fact of the matter is, most people have no idea how effective their services are. And a lot of people, including clinicians, would just as soon not know. So this is a scoreboard, or what I call a scoreboard, a self-completed overview of my recovery experience. And then this is Johnny B. Good's scoreboard. If we have Johnny B do the ORS, shows up as a 23, come down here to this graph between 0 and 40 and put that O for the ORS right here, representing that 23. What does that 0 tell us, or what does that O tell us just from appearances? Well, only thing I can say is it's important to recognize whether or not this initial ORS is above or below the clinical cutoff. I hate that they kind of called it the clinical cutoff, but fact of the matter is there's been over 900,000 ORSs that have been used to calculate what's the average score for people who either are concerned enough about something in their life that they're seeking services to experience a change or not. And that's the clinical cutoff. So it really is kind of a distress marker. People above it, not so much worried about changing something in their life. People below it, there's definitely something that they want to change. So in this case, we could say Johnny B, there's something that could be better. And this is from Johnny B's perspective. So comes in the next week and has a 20. Comes in the next week and has a 29. It doesn't take a rocket scientist to figure out something has gotten better between weeks 2 and weeks 3. Something happened in Johnny B's life, and that invites the conversation. Well, instead of a 29, what if it was an 18? And again, it doesn't take a rocket scientist to figure out Johnny B's life isn't getting better. And it invites that conversation about, wow, something is amiss. And I'm really curious about what you think that is and how you might go about beginning to address it in a way that will help your life suddenly take off in a different trajectory. Well, so if we run this on out over 12 sessions, what you can see is that Johnny B's ORS score went from a 23 to a 31. That is an 8-point increase. And again, it's from Johnny's perspective. It's not what I think Johnny has experienced in Johnny's life, which in the research literature, it's what is defined as reliable change. A 6-point increase from the first ORS to the last ORS is reliable change, meaning it's likely going to sustain itself.
Oh, big cow.
Because it started below the clinical cutoff, increased by 6 points, and exceeded the clinical cutoff, that is what in the research literature is referred to as clinically significant change. And some of those researchers actually use the R word and will say this person has recovered, meaning they're likely going to sustain whatever changes have produced this improvement of 6 or more points. And so it's a way of quantifying the conversation that you're having with the peer, but it's from their perspective. It's from their point of view, and they can see it right there on the piece of paper. So it's not a question of me interpreting it necessarily. It's more about being open to having this conversation with the peer. So, and again, I would show you this KPI video, but I think given the interest, given the time, it would be better just to move on and show you again these 3 KPIs, key performance indicators. The first one is the initial outcome rating scale score should be below 35. And if it's above 35, kind of the question in my mind is, so why are you coming to see me if your life is that good? Now, I wouldn't say that, but that's kind of the point. And in many cases, it's because the person doesn't know how to reflect as far back as 7 days from now. It's all about how I feel right now. And we kind of talked about that earlier, Libby. And so it kind of takes some people some time to figure that out. And again, it's over 800 administrations. The average initial ORS score is between 18 to 20. And our goal is to have less than a third of initial ORSs over the clinical cutoff. And that clinical cutoff number varies whether you're talking about adult or child or adolescent. And then the reliable change index, again, 6 points from the initial ORS, and then the clinically significant change, 6 points and cross the clinical cutoff. So how do we do this performance support? Well, sometimes it begins with technical support. Not everybody knows how to use a computer, or they don't necessarily know how to use the technology that is key to how they're going to document the services that they provide. And then there's learning support. How do you teach people how to actually administer and interpret and understand the results that they get when it comes to the forms that you're using, not just the ORS and the SRS. And then there's performance support. And fundamentally, it's about helping people learn how to do reflection and self-assessment. And there's a PCoMS report that you have a link to in the handout. It's a spreadsheet, but it's about being able to recognize challenges and successes, and fundamentally be able to do peer support or co-reflection to discuss challenges and celebrate successes. I'll abbreviate that DCACS because it's going to come up over and over. When we do quality improvement visits, it's about providing proficiency feedback and then celebrating challenges or discussing challenges and celebrating successes. And then look at your professional development plan. What is it you want to get better at? Are you wanting to spend the next 3 months really focusing in on motivational interviewing skills? Are you really wanting to learn advocacy skills? Is there something about doing individual interactions or group interactions? Whatever it is, what's your professional development plan? And let's talk about that. And then the fourth aspect of it is performance support within communities of practice, getting together with others, talking about your PCoMS data and what your data is showing in terms of both your program's effectiveness, but also your effectiveness as a service provider, and then discussing challenges and celebrating successes. I know it sounds like a broken record, but I can't emphasize enough the importance of discussing challenges and celebrating successes. So here's the outline of what a typical performance support conversation would look like. First of all, what does the client, peer, or resident say is going on? And then are they engaged? What are their RRS, which is the relationship rating scale, and the GSRS was the group session rating scale. How are those numbers showing up? Are they engaged? Are they providing feedback? Or are they just kind of participating and at a cursory level? And then thirdly, what have you, Mr. and Mrs. Supervisor, done differently? And then what could be done differently now? What do you think? And then what other resources could be allied? And then number 6 is how is it really time to fail successfully? And by that, I'm referring to the fact that you're not going to be everybody's flavor of the month. There's going to be folks that just you're not going to gel with, or there would be somebody else who has a different mindset or a different theory of mind that might work better with this individual. And failing successfully means being able to hand people off to those other resources. So the longer without change, the quicker you should get to number 6. And that warm handoff is an important part of how you learn to do peer performance support successfully. So again, I'm not going to go into a whole lot of depth. I just want you to know that this spreadsheet's available. You can download it. And it's got a number of different sheets in it, different aspects. This is an individual's caseload or peer supervision, a peer load. And this is another view of a recovery community organization with each service provider. And then there's other ways of being able to talk about whether or not the organization is really producing the sort of results that it's after. And it's about being able to graph this material and do it in a way that allows others to be able to express whether or not you're meeting your vision and your mission. And this is a program report, depending on what your key performance indicators are. But fundamentally, it's about, are we able to show people who are making progress? Are they doing planned transfers? I prefer planned transfers to successful discharges, and unplanned transfers to calling it an unsuccessful discharge. And so again, putting this up on the wall and monitoring it from month to month so everybody knows how we're doing is a great way of showing this progress. So really quickly, if you go to Better Outcomes Now and you click on the PCoMS link, it will take you to the PCoMS measures. There is a consent form that basically you agree to not put numbers on the form or to change it in any way. Put in your email address and it will take you to this page, which is, and actually there are 38 languages that it's available in now. Any individual service provider can download the forms and use them for absolutely no cost. If you want to implement it as an organization or an agency, there are group licenses that are very affordable. And it's just a matter of getting a hold of Dr. Duncan and basically saying, I need, and he'll do a trial period where you get 3 months basically to see whether or not you want to continue using bond or using the paper license, paper scales in your organization. I will point out down here at the bottom that there are oral ways of administering the ORS and the RRS, and there are group measures and there are peer measures. And perhaps most importantly, if you think people who have computer skills don't have a sense of humor, the English measures are actually under that English flag as opposed to the American flag. But there's versions of the ORS and the SRS and the RRS for adults, for adolescents, for children, and young children. So you can get the feedback from every person who's participating.
Okay. Thank you so much, George.
You're
really
very
interesting
welcome.
presentation. I do appreciate you, and thank you for presenting at our conference. Thank you to all of the attendees for your attention to this vital matter of how we improve outcomes. I'm going to put a link in the chat. If you can give us feedback about this presentation, we'll pass that on to George. And also you can request a certificate of attendance for this session. Please save the date, April 17th, 2024. We're going to be having a peer supervision conference.